Gracias, doctor Wong, por su excelente plática. Y bueno, queda abierta la mesa redonda para las preguntas. Espero que haya varias inquietudes. Invitamos al doctor Contreras para que pase aquí a la mesa de preguntas. Ah, sí. Tenemos una pregunta que quedó pendiente.
Voy a repetir la pregunta. El uso de la sonda de Doppler es interesante y en úlceras ha demostrado su valor porque aunque se vea una úlcera sin estigmas, todavía encuentra uno el sonido y puede inyectar. Pero aquí en varices del fondo gástrico, se antoja que la sonda podría identificar sitios en donde conviene inyectar otra vez más histoacril, pero no prevendría el embolismo, que sería una de las ventajas. Y el ultrasonido endoscópico comentábamos que al ver el sitio de la inyección y el vaso comunicante, puede dirigir una inyección ahí e inclusive es muy interesante que si uno oblitera el vaso comunicante, la gran masa de conglomerados de varices gástricas desaparece al inyectar el vaso comunicante.
Yes, thank you for that question. So, yes, the one advantage that EUS has is that you can have direct visualization and you can see all the communicating vessels and the collaterals, and you can see the gastric varix getting filled with the glue. So that is the beauty of EUS. I think the technique that we have, I mean, the aim that I have is to try and keep things simple. I'm not sure that, I think there are advantages of having things complicated, but I do like to keep things simple. I think in our hands, we've been doing it for 3 years now. At our institution, we've been using exactly the same technique with the 4-carbon histoacryl, used undiluted and with the Doppler probe. And touch wood, we haven't had any major complications as of yet. I would say that we don't have as much resources as the Mayo Clinic in Rochester, so we can't CT all these patients after the procedure. So maybe we are missing things because I think, as Dr. Wong Ki-song says, a lot of these patients do actually have asymptomatic glue pulmonary embolization. But then again, what does that mean? I mean, what does that mean when it's asymptomatic? And you have to balance that with the risk of death. I mean, these patients, when they have active gastric variceal bleeding, the risk of death is significant. It's really high, So balance that with the risk of asymptomatic pulmonary embolization.
Una pregunta para los doctores Wong, para los dos. En el contexto de trombosis portal en el paciente con sangrado por varice gástrica, ¿debemos tener alguna precaución al realizar inyección pensando en la redistribución de flujo hacia las varices esofágicas?
So if you're talking about the technique that we use, so unlike BRTO, where we sometimes try to obliterate the shunt, we do not do that because that's a natural portosystemic shunt to decompress the system. If you block that shunt, where does the blood go? Okay, so you're going to develop ectopic varices, you're going to develop worsening of esophageal varices, okay? So unlike BRTO, we do not occlude the shunt because that's the main shunt through which the system is decompressing, okay? So that's one difference between our technique and the standard BRTO technique.
Okay, so your technique is just temporarily to obliterate the shunt to do the proceeding, and after the shunt is patent, right?
Correct. So with our technique, you don't want to obliterate that shunt. And BRTO, unfortunately, they sometimes do because alcohol essentially diffuses down into the shunt. But again, that's a body system to decompress. So if you're blocking that shunt, the blood has to go somewhere, and that's where you have patients with esophageal varices that bleed, or they start to develop varices where they should not be developing varices, stromal varices, intra-abdominal varices, okay? So my thinking is that, again, we don't want to be occluding that shunt. We should leave it open.
Thank you. ¿Alguna otra pregunta? ¿Le pueden pasar el micrófono?
Oh, sorry.
Para el doctor Luis Wong, for you. ¿Cuál es la ventaja de inyectar el cianocrilato por endoscopía? Si ya entraste ahí, identificas el shunt, hiciste la oclusión, ¿es posible inyectar el cianoacrilato directamente por el catéter? ¿Cuál es la ventaja de inyectarlo por endoscopía?
That is a great question. So essentially, can the interventional radiologist inject glue from a catheter? The short answer is absolutely not, okay? Because first of all, you have high flow that's coming from the gastrovaruses toward the balloon catheter. You're going to be injecting glue against that flow. What's going to happen to the glue is actually going to glue the catheter to the shunt. And then you're in big trouble, because then you may not be able to remove that shunt, okay? So our interventional radiologists would never inject glue through the catheter because of the risk of occluding that catheter in the shunt, okay? It's similar to what we do when we inject glue for the varix with standard sclerotherapy needle. We sometimes glue the needle right into the varix. It's the same problem if you were to inject glue through the catheter, through the IL catheter. So it's not a good idea to do that.
¿Alguna otra pregunta? Entonces yo tengo otra pregunta para la, another question for you.
Me? Okay.
Ya. En el caso de una hemorragia aguda, nos sugieren su manejo que se puede utilizar un clip o ligadura y después el tratamiento con el cianoacrilato. ¿Cuánto tiempo después sugiere de haber tratado la hemorragia aguda con un clip o una liga hacer el tratamiento con el cianoacrilato, con el pegamento?
I think you have a good 24 hours, and that's what we have usually, So we control the active bleeding, and then the following day, we're getting the CT contrast to see if they have a shunt or not, and then arrange with the interventional radiologist to do the combined procedure if they have a shunt. So I think that gives you a good 24 hours to be able to plan properly your definitive procedure, okay?
Thank you. Gracias. Doctor Contreras.
A question for you. Why is splenectomy the absolute indication for the splenic vein thrombosis? Why you mentioned that for the splenic vein thrombosis you should do a splenectomy? Why can those patients cannot be glued?
Yes. So those patients probably can be glued, but in terms of the traditional treatment, if it is due to splenic vein thrombosis or splenic vein stenosis, the traditional treatment is splenectomy, and that, if you do that, you don't need to follow them up. The thing with glue is that you do need to follow them up. I mean, there is a surveillance protocol, but if you can do a splenectomy, you've dealt with the issue, and they don't need to follow up. So you have no follow-up needed. One thing that the interventional radiologists have been doing in our institution is that they've been doing splenic arterial embolization, and that actually works quite effectively. They do it over several sessions, and you don't need surgery for that. So that's been done.
Doctor Soto, por favor.
Muchas gracias. Gracias por sus excelentes ponencias. Para el Dr. Wong, Dr. Richard Wong, in actively bleeding gastric varices, don't you think EUS guided injection is superior to the traditional technique? Because you can do it without seeing all the blood in the gastric chamber.
Yes, thank you for the question. So I think your question is, in actively bleeding, shouldn't we just do EUS guided glue therapy? Yes, I think a lot depends on local expertise. I think if you have somebody who's available, who knows how to do it, it can certainly be done. One thing I would say though is that, so it depends on your local expertise. So that's the simple answer. But there is a small risk of glue causing problems with the endoscope. So glue can also sometimes stick to the endoscope, and you really don't want a glue to stick to an EUS scope. It's a lot more expensive than a diagnostic gastroscope. So if you want to have glue stick, I'd rather stick it to a diagnostic gastroscope than an EUS scope. But you got to be, I think it's a very confusing issue in terms of the technique. I would love somebody, maybe we can get together, or somebody to actually do a study to look at all these different techniques, because that is what's confusing to the gastroenterologists and to the hepatologists out there.
I have another question. I was really impressed in last DDW because people from United States are injecting absorbable gelatin sponge instead of glue, and they are showing that it has less risk of embolization, and perhaps we don't have to do this complex procedure with BRTO. What do you think about that? Is is this the final stage of glue?
I think it's too early to tell, you know. I mean, everything that starts looks exciting. So we just have to see. I mean, you know, you're still injecting sponge, and I think, you know, the sponge itself can also embolize. I mean, not because it did not embolize in those studies doesn't mean that it will not embolize, you know, time will tell. So I think everything that you inject, you know, has a risk of embolizing, right? Whether it's sponge or coil or glue, you name it. So I have some tempered enthusiasm with respect to the use of sponge for hemostasis of gastric variceal bleeding. So.
Thank you very much. Muchas gracias por estas excelentes ponencias y muchas gracias por su permanencia. Hasta luego.